for providing immediate anesthetic recovery in a post-anesthesia care unit. The first step is to identify the patient with at least two identifiers to make sure you're dealing with the right person. You receive the handoff report from the circulating nurse and anesthesia provider, including procedure performed, the range of the vitals, any complications, estimated blood loss, other fluid loss, replacement fluids during surgery, the type of anesthesia or meds given, the type of airway and size they used, extent of surgical wound, restrictions to movement of positions during surgery, and any other preoperative medical and or nursing diagnoses. When they come into the PACU, make sure you review the surgeon's orders. Consider the type of surgical procedures and restrictions to movement and type of anesthesia used. You perform hand hygiene, put on some gloves, and perform a thorough patient assessment, including vitals, O2, pain assessment, respiratory, cardiac, neurological, GI assessment, urinary assessment. Make sure you look at all the metabolic and fluid statuses, assess the surgical sites, the drains, the skin integrity, the safety of the patient, and the general anxiety or cognitive level of the patient. You take the vitals and monitor pulse oxygen and initial stabilization, and you discharge from level 1 care based on specific criteria, not at the time limit. The criteria should be assessed for airway patency, oxygenation, hemodynamic stability, thermal regulations, intake, outtake, two patency, dressings, pain, comfort. All this is defined by your agency. So while you're doing your assessment, get an assessment of all vitals every 5 to 15 minutes until the patient stabilizes, or more frequently if clinically indicated. Maintain a patent airway for the patient after general anesthesia. Position the patient on the side with face down and neck slightly extended. Never position patients with hands over chest. This reduces the chest expansion. Place small folded towels or small pillows on the patient's head. If patient is restricted to supine, elevate the head of the bed like 10 to 15 degrees. Extend the neck and turn the head to the side. Have Emerson basin present just in case if the patient becomes nauseous. Encourage the patient to cough and deep breathe upon awakening and every 15 minutes afterwards. Suction artificial airways or oral cavities as secretions accumulate. Call the patient by name like a normal tone of voice. If there's no response, attempt to arouse the patient by touching or gently moving a body part. Assess their circulation perfusion by inspecting the color of the nail beds, mucous membrane, skins. Assess closely for any behavior or clinical changes that reflect potential cardiovascular pulmonary changes. If the patient has general anesthesia, as the patient arouses, introduce yourself and orient him or her to the settings what they're currently in. Monitor their sensory, circulation, pulmonary, and neurological responses after any spinal or epidural anesthesia. Monitor their source of intake and output with any drains, tubings, including the color, the amount, the odor, consistency of drainage. If you see a dressing that's starting to get soaked, make sure you dot around it with a black pen and time, and make sure you check the area every 10 to 15 minutes to make sure there's any notable changes in size of the drainage. You got to observe them in the PACU until they regain movement in their extremities. Assess their respiratory status and mobility in the lower extremities. Drowsiness is apparent after IV sedation. Have the patient let them know if they're warm or cold and help them with that. Reinforce pressure dressing or simple dressings if it is. Continue to be soaked. Monitor incision and surrounding tissue. Inform the surgeon if any unexpected bloody drainage and reinforced dressing is indicated. Always inspect the condition and the contents of any drainage tubes and collected devices. Note the volume and character of it. If a NG tube is present, assess drainage. If not drainage, check placement and irrigate if necessary with normal saline. Monitor and maintain IV fluids. Observe the IV sites for any infiltrations. Try to provide comfort to the patient, like do some mouth care, provide warm blankets, rewarming therapy, can promote warmth and minimize shivering, help with position changes and provide supportive pillows, continue monitoring pain as the patient awakens and until the transfer to a surgical unit or discharge. Explain the patient's condition to the patient and inform plans of transfer to a nursing unit or discharge. When the patient condition stabilizes, contact anesthesiologists to approve transfer to nursing unit or release to home. Before discharge to home, for ambulance surgery unit, provide verbal and written instructions.